stain H&E, high magnification. Surface epithelium, basement membrane, lamina propria, gastric pits, gastric glands in neck region, parietal cells, lamina propria. Once again on the right, lamina propria, blood vessels, mucous neck cells, parietal cells, chief cells or zymogenic cells, sir.
Super.
Stomach basal region of gastric of undic mucosa, stain H&E, high magnification, gastric glands, parietal cells, lamina propria, lymphatic nodule, muscularis mucosa, chief or zymogenic cells, lamina propria, muscles, smooth muscle strand, gastric glands, basal branching, chief or zymogenic cells, and submucosa, sir.
And you see the muscle going in, and that's why they have written muscularization of lamina propria. Normally, muscle should not go up. For gastritis, I will just put, remember ABC. A is autoimmune gastritis. B is bacterial gastritis, biological or bacterial, like H. pylori. C is chemical gastritis. Villiform surface changes, edema of the lamina propria, and muscularis mucosa hyperplasia, and the extension of muscle into the lamina propria. These are all the criteria for chemical gastritis, and you see it in biliary reflux and the NSAID use. This is from the pyloric region. Even cardia, it will look like this. No parietal cell at all. Whereas in fundus and body, you see a lot of parietal cells.
Figure 12.13, pyloric region of the stomach, stain hematoxylin and eosin, medium magnification, sir. The top one shows surface columnar mucous epithelium, 2 muscle fibers from muscularis mucosa, 3 gastric pit, 4 lamina propria, 5 pyloric glands, transverse section, 6 muscularis mucosa, 7 submucosa, 8 gastric pits, 9 pyloric glands, longitudinal section, muscle fibers from muscularis mucosa, lymphatic nodules, venules and arterioles. Figure 12.14, pyloric duodenal junction, longitudinal section, stain hematoxylin and eosin, low magnification. The top first on left shows pylorus and 11 duodenum, sir. So
that's very important. See, this is the junction. We have to understand. See how the surface is thrown into villi. Presence of villi is small intestine.
2 stomach epithelium, 3 gastric pits, 4 mucosal ridges, 5 lamina propria stomach, 6 pyloric mucous glands, muscularis mucosa, 8 pyloric sphincter, 9 muscularis externa stomach, myenteric nerve plexus stomach. 12 is intestinal epithelium, 13 villi, 14 intervillous spaces, 15 intestinal glands, crypts of Lieberkühn, lymphatic nodule, muscularis mucosa, duodenal glands, submucosa, muscularis externa duodenum, myenteric nerve plexus duodenum.
When you see villi like this, it's a small intestine. But you know there are 3 parts of small intestine: duodenum, jejunum and ileum. And duodenum will have the submucosal glands. These are known as Brenner's glands. These submucosal glands should not go into the lamina propria. So if you see here, this is the muscle layer. This is the muscularis mucosa. These Brenner's glands are in the submucosa. And when these Brenner's glands are seen in the lamina propria above the muscularis mucosa, then it is known as Brenner gland hyperplasia. Sometimes they may form a big mass, the Brenner gland. Then it is known as Brenner gland adenoma. To say it as ileum, you have to see the Peyer's patches. You all know the lymphoid aggregates, which is a normal component. Whereas here the lymphoid nodules are usually abnormal. So by looking into the submucosal glands, we can say it's a duodenum. By looking into the lymphoid aggregates, we can say it is ileum. Jejunum doesn't have any specific finding. And when you logically think about it, it's very difficult to take a jejunal biopsy, because the duodenum they can reach from the stomach, and ileum they can reach from the cecum through when they are doing colonoscopy. But jejunum, usually it is not possible to get biopsy from them.
Figure 13, structural differences between the wall of the small intestine and large intestine, with emphasis on different layers of the wall. So the mucosa, on the right side, mucosa, submucosa, muscularis externa and serosa. Epithelial cells, then globulate cells, intestinal gland, crypt, lamina propria, muscularis mucosae, circular muscle layer, myenteric plexus, longitudinal muscle layer, on villi, microvilli, and capillary network, nerve, lacteal, vein, artery. and lymphatic nodules.
Yeah, the lacteals are the lymphatics. These lymphatics are very, very important to take the absorbed nutrients to other areas. These goblet cells are seen from the small intestine to the large intestine. The number of goblet cells are increasing the minute you are going from right to left. You see, imagine how many goblet cells are there in the small intestine and how many goblet cells are there in the large intestine.
Columnar epithelium, lamina propria, muscularis mucosae, submucosa, muscularis externa, serosa. Left
Super.
side, epithelial cells, goblet cells, intestinal gland crypt, lymphatic nodule, blood vessel, circular muscle layer, myenteric plexus, tinea coli, longitudinal muscle layer.
Tinea coli is a very important one to recognize large intestine from small intestine.
The figure shows the duodenum of a small intestine, stain hematoxylin and eosin. Low magnification. Number 1 is intervillous space, goblet cells, duodenal gland in the lamina propria, intestinal gland and lymphatic nodule, myenteric nerve plexus. Again, villus. A is lining epithelium, B is lamina propria, 8 is the intestinal gland, 9 muscularis mucosa, 10 smooth muscle fiber, 11 lacteals, 12 muscularis mucosae, 13 duodenal gland in the submucosa, 14 muscularis externa. It contains inner circular, outer longitudinal. 15 serosa.
And again, you have to remember the uniform size shape distribution. I may not be telling in all the pictures, but throughout the GIT, the normal mucosa should have uniform size shape distribution. That is very, very important. And then you can see all of them are sitting over the muscularis mucosa. This black line is the muscularis mucosa. How nicely all these glands are sitting on the muscularis mucosa. And you see the Brunner's gland beneath the muscularis mucosa. You have to remember, even though we are talking about all the 4 layers, in biopsies you can see only the mucosa and submucosa. If you see in the biopsy the whole wall, what will you do? That's the critical value. You have to immediately call the surgeon. They might have perforated.
Figure 13.2, small intestine, duodenum, transverse section, stain H&E, 25 times magnification. Simple columnar epithelium, villi, lacteals, lamina propria, duodenal glands, lamina propria, intestinal glands, muscularis mucosae, submucosa and muscularis externa. Figure 13.3, small intestine, jejunum, transverse section, stain H&E, low magnification. On the top it's labeled plica circularis. Then lining epithelium with goblet cells, muscularis mucosae, submucosa, lacteal, lamina propria, lymphatic nodule with germinal center, muscularis externa with inner circular and outer longitudinal smooth muscles, adipose cells, intervillous spaces, villi, artery and vein in submucosa, intestinal glands, submucosa, myenteric nerve plexus, and then serosa.
So figure 13.4, intestinal glands with Paneth cells and enteroendocrine cells, stain H&E on high magnification. Here it's a mitotic cell, then goblet cell, neuroendocrine cells, Paneth cells, muscularis mucosa. On the other side, mitotic cell, intestinal glands, enteroendocrine cell, Paneth cells, and muscularis mucosa.
So here they are introducing some types of cells, isn't it? So you all know what is goblet cell. Goblet cell is a mucin secreting cell, and that will be a flask-shaped cell with a peripherally placed, pushed or compressed nuclei. So that is the goblet cell. The cytoplasm usually will be clear. And then another cell you have to remember, which is very specific for small intestine, and that is Paneth cell. Again, it's a pyramidal shaped cell, and it will have eosinophilic pigment over the, or granules over the nuclei. Supranuclear eosinophilic granules, Paneth cells. They are very specific for small intestine. They may be seen, few of them can be seen in cecum, but in the colon it should not be seen. If you see the Paneth cells in colon, what can you call Paneth cell metaplasia? Paneth cell metaplasia can be seen in inflammatory bowel disease, especially in Crohn's or ulcerative colitis. And then they are talking about enteroendocrine cells. They are also pyramidal shaped, but you see the granules. These are infranuclear granules. Some people ask me how to identify what is below and what is above. See the nucleus and the basement membrane. This basement membrane is very important. For example, in a glandular structure, the basement membrane can come here. The granules can be here. See the relationship with the basement membrane. Away from the basement membrane, then that is supranuclear. If it is close proximity to the basement membrane, it is infranuclear. For example, I will draw a cell here also. I will draw the granules here. Okay, so this is infranuclear. Okay, yeah, and this is supranuclear. Immunohistochemistry will help you because these endocrine cells will be positive for neuroendocrine markers.
13.5 small intestine, jejunum with Paneth cells, stain Mallory-Hazan stain, 40x magnification. So these are villi. Then there's simple columnar epithelium with goblet cells, muscularis mucosa and submucosa. Then there's lamina propria, blood vessels, intestinal glands, and Paneth cells.
Figure 13.6 small intestine, ileum with lymphatic nodules, phase patch, transverse section, staying with hematoxylin and ileum. On low magnification, staying surface epithelium, villi and with lamina propria, lacteal, intestinal glands, germinal centers of lymphatic nodules, which is phase patch, submucosa, serosa, and villi also in transverse section, lacteal, lamina propria, intestinal glands, lymphatic nodules, muscularis mucosa, which is disrupted, muscularis externa, 2 layers of the inner circular river and outer longitudinal river.
You all know typhoid. Typhoid phase patches are affected.
Villi of small intestine, longitudinal and transverse section, stain, periodic acid shift, medium magnification. Villi, surface epithelium, striated border microvilli, lamina propria, smooth muscle fibers, central lacteal, goblet cells, basement membrane, capillaries.
When you do PAS, this is the cell membrane and this is the fuzzy area. This is the fuzzy area. So the PAS should be above the cell membrane. Whereas in inverted villi, it will be beneath the cell membrane. The IHC we can do is CD10. Another point you have to remember, see, this is the tangential section. See the cut section of the papillae. This is the basement membrane. In papillae, the cells are away from the basement membrane. You see in the fibrovascular core, you see the blood vessels and you see some fibroblasts. This is the papillary processes. Whereas when you draw the glands, let us again start with the basement membrane and then the cells will be inside the basement membrane. The glands will be either empty or they may have some secretions. So this is gland and this is the transverse section of papillae.
Sir, large intestine, colon and mesentery, panoramic view, transverse section, stain H&E, low magnification. From the top, we have Tinea coli, mesenteric nerve plexus, serosa. Then comprising the mucosa, we have epithelium, intestinal glands, lamina propria, and muscularis mucosa. Next, we have submucosa, lymphatic nodule, once again Tinea coli, lymphatic nodule again, temporary fold, muscularis externa, mesenteric nerve plexus, outer longitudinal muscle layer and inner circular muscle layer, serosa mesentery, and lastly mesentery, sir.
Super. And how many Tinea coli do you see?
3 are there, sir.
Yes, 3 of them. Where are the blood vessels coming into the intestine tract? This is anti-mesenteric. Okay?
Yes, sir.
And this is the mesenteric. So the blood vessels, they go through the mesenteric end. There is an applied histology, applied aspect there. Whenever there is a diverticulum, in the diverticular diseases, what happens? There is increased intraluminal pressure. That increased intraluminal pressure pushes the mucosa and the lamina propria and the submucosa. So they pass through the weakest portion of the wall of the colon. The weakest portion is where the blood vessels are entering into the colon. Diverticular process is nothing but herniation of the mucosa and submucosa through the muscular layer at the weakest portion, because there is increased intraluminal pressure, the cells can go. So in diverticular process, all the diverticulum are seen in the mesenteric end. They always will have a leading blood vessel, because that's where the point of weakness is there. Whereas in congenital diverticulum, they will happen always in the antimesenteric border. They will have all the 4 layers. The whole thing will deviate. So that's the difference between the acquired diverticulum and congenital diverticulum. So acquired diverticulum will be always mesenteric end. It is herniation of mucosa and submucosa, only 2 layers of the wall of the colon, and they will have a leading blood vessel. Abhijit, now you tell me what is the criteria for congenital diverticulum.
Yes, sir. Sir, in congenital diverticular, the diverticula will be on the antimesenteric end. There will be no leading blood vessel and will contain 4 layers. Will contain all the 4 layers, sir.
Super.
Large intestine, colon wall transverse section, stain H&E, 30 times magnification. Starting from top left, there are absorptive columnar cells, goblet cells, lamina propria, intestinal glands, lymphatic nodule, goblet cells again, another lymphatic nodule, muscularis mucosae, and submucosae.
So figure 13.10, large intestine, colon wall, transverse section, stain hematoxylin and eosin, medium magnification. On top, we have temporal folds, mucosa and submucosa, intestinal glands, lining epithelium with goblet cells, lamina propria, muscularis mucosa and submucosa, muscularis externa, serosa, myenteric plexus, to the right, intestinal glands, longitudinal and cross section, muscularis mucosa, submucosa, lymphatic nodule, myenteric plexus, tinea coli, blood vessels, adipose cells.
Figure 13.11, the appendix, paranomic view, transverse section, stain hematoxylin and eosin, low magnification.
Lining epithelium with goblet cells, muscularis mucosae, lamina propria. 4th is germinal center of the lymphatic nodule. 5th is intestinal gland. 6th is diffuse lymphatic tissue. 7 is muscularis externa, composed of inner layer and outer longitudinal layer. Next is submucosa. And lymphatic nodule with germinal center. 10 is serosa. 11 is blood vessel in submucosa. 12 is parasympathetic ganglia of the myenteric nerve plexus. 13 is adipose cells.
Appendix is a hybrid of small and large intestine. It will have mucosa like a large intestine, no villi. Whereas in the lymphoid aggregates, it will be like a ileum. In the appendix, again grossly looking at the slide, you can see the whole section. When you get appendix, you have to take a section like this, and then you have to give 2 sections, one from the center and the other one from the resection. This is the resection margin. You always ink the resection margin. It's always better, because the carcinoid tumor sometimes can be incidental finding. And there is a carcinoid called as goblet cell carcinoid. Now it is there is a name change there, goblet cell carcinoma, adenocarcinoma. And that will have incidental finding, and at that time they may want to know whether it is there in the margin or not. So you ink the margin and then take a section like that. So usually appendix, when you see histologically, it will have 1 longitudinal section and 2 cross sections. And when appendix is looking normal, you submit all the tissue, all the appendix. You can give both the longitudinal sections, and then you can serially slice these things and you can submit all the sections, because we want to see whether inflammation is there. Whenever they remove the appendix, there should be some pathology. Criteria for acute appendicitis is presence of neutrophils in the muscularis propria or muscularis externa. That is very, very important criteria you have to remember. You may ask, sir, you told yesterday cryptitis and cryptapsis, why we cannot apply it in appendix? Because in appendix you got lot of fecolith. And the fecolith is a chemotactic factor for neutrophils. Okay, so that's why the neutrophils may be there in the mucosa. That's why you should not use it as a criteria. And another common pathology we see in our country is a lot of eosinophils. That is known as eosinophilic appendicitis. You cannot call it as chronic appendicitis. It is a eosinophilic appendicitis. And then you may see some bugs in the lumen, Enterobius vermicularis, and then carcinoid tumor in the tip of the appendix. So in the appendix, you have to look for these three things. Number one, acute appendicitis. Number two, eosinophilic appendicitis. Number three, oxyuriasis. And number four, carcinoid tumor. There is no chronic appendicitis, there is no subacute appendicitis in pathology. They are all clinical terminology. Fifth thing you remember, mucinous neoplasms of appendix.
Known as the surface epithelium, lamina propria, longitudinal fold, intestinal gland in the mucosa, lumen, venule, arteriole, submucosa. 9 is adventitia, lymphatic nodule, muscularis mucosae, adipose tissue, muscularis externa, A is inner circular layer, outer longitudinal layer, 14 parasympathetic ganglia of mesenteric plexus, and 15 is arteriole and venule.
Why they called adventitia rather than serosa?
Sir, there is
no mesothelial cells lining that. The rectum is part of it is intraperitoneal and part of it is retroperitoneal or extraperitoneal. The extraperitoneal rectum won't have the mesothelial cells. That's why it is called adventitia. Inking of the surface is very, very important because as in the esophagus, these retroperitoneal part of the rectum may not have the mesothelial cells. Okay, so inking of the surface of the rectum is very, very important because when you take section like this and for example there is a tumor, the clinician may want to know whether it is reached the margin or not. As this is adventitia, if the tumor is there here, that means they might have left some tumor in the patient. Okay, so it is known as R1 surgery. The resection margin is not free of tumor. The resection in R0 surgery, resection margin should be free of tumor.
Anorectal junction, longitudinal sections, stain, hematoxylin eosin, and low magnification. Simple columnar epithelium, lamina propria, intestinal gland, muscularis mucosae, submucosae, and muscularis externa, which contains the internal anal sphincter, and anorectal junction is the stratified squamous epithelium, lamina propria of anal canal, internal hemorrhoidal plexus, and the lymphatic nodule, external anal sphincter, skeletal muscle, and levator ani muscle is also.
So that is the T zone. There are, I told you there are 5 transformation zones in the GI tract. Abhijit, do you remember?
First junction is at the lip borders. Esophagus, stomach, sir.
Super. Esophagus, stomach. After lip, it is stomach and esophagus.
Then stomach and duodenum from small intestine to cecum, sir. And lastly, rectum and anal canals, sir.
Super. Okay. So please remember all these 5 transitional zones. Yes, we are done.